Okay, this lecture is on the lower extremity return to sport. This pre-lecture material is given by myself, Michael Jeanfavre. I'm a physical therapist with the outpatient orthopedic sports medicine team with Stanford Healthcare, and Taylor Douthit, who is currently with the Andrews Institute in Dallas, Texas. Okay, so there is a ton of information that currently exists in regards to the lower extremity and effectively evaluating someone's readiness and risk stratification for return to sport. Today's lecture really is the tip of the iceberg, the initial launch and giving the foundation for the principles and the concepts around the definition of return to sport and how the decision making is otherwise made. Additionally, the actual live lecture itself also helps to build upon this foundation, but with recognition that there is an extensive amount of information that exists on the topic at hand, and that there will only be further information that comes out as technology, innovation, and rehab and sports medicine continue to develop and evolve and mature over the coming years and decades. And so hopefully this is just a launching pad that gives you contextual and literacy around the subject matter of lower extremity return to sport and having a better grasp on your standard operating procedure on how to go about determining someone's readiness with the current standard of practice, as well as how to then extrapolate that and build upon it as your journey and your career continue to prosper and that the more information becomes available to us. Okay, so today, this is the outline for the entire lecture and lab. Today, we will focus predominantly on the first two bullet points that you see there, the applying decision-based model for return to sport, defining what return to sport is, and then discussing the definitions and the current state of affairs as it applies to the first topic at hand is going to be applying the decision-based models for return to sport.
So why do we need to have a model for return to play or return to sport? I think it's important to clarify the process for the clinicians when determining when an athlete is ready to go back. It's been suggested that with a previous injury, you're about a fourfold increase in risk of re-injury based off of what this paper is. Certainly, there's a lot of other statistics out there talking about other increased risks depending on what type of injury you had if you return before a specific timeline. I think we commonly see that with the ACLs that we work with. I think it also provides structure and helps decrease the controversy. Like I mentioned previously, it's a little bit of an art, a little bit of subjectivity to it, or this can outline someone's decision making a little bit better, especially if they implement it. And it allows assistance to the physician, the PT, or the athletic trainer, whoever is going to be the ones to make that call. Certainly, I've worked with PTs or with physicians who have said, yeah, you're good on my end, only checking with me as you need to. You're clear when your PT says you're clear. And obviously other instances, the physician can also be the one who says, all right, when I say it, you're good. But I've been put in that spot a few times, and I've found this to be helpful. Also identifies the gaps in practice where the evidence is lacking and helps give us a framework where we can potentially. So how do we define return to play? What does it mean? It's a rational model. It talks about the advantages. And so this basically proposed a, this is their big little infographic. So step one speaks about evaluation. And basically what it is was assessing the athlete's recovery. So a few things to take in consideration. Certainly then once you take all those things into consideration from evaluating the health risk, that's where you really want to evaluate the risk factor. Certainly some things to take in consideration. And then what is the that leads you into step 3. This can't be used without knowing the participation risks. So the things that go into the consideration of it are time. So something that recently.
Okay, great. And now we'll be moving on to the expected timelines for return to sport, where we'll discuss the tissue healing timelines, the functional performance timelines, and then the documented return to sport timelines that currently exist. So recognizing that there's the one timeline where the whatever tissue is otherwise involved in the surgical procedure or the injury needs sufficient time to have its adequate integrity and capacity to be able to tolerate athletic-based training. But then there's also the functional timeline as far as the athlete actually being able to regain their strength, range of motion, etc., which is a bit more variable, yet there are still predictive components that we can share with this. Okay, so this next section will be on the expected timelines for the return to sport, tissue healing timelines, the functional performance timelines, and the hybrid model that exists when utilizing both of these, which is the current standard of care within outpatient orthopedics and sports medicine and performance and sports physical therapy. All right, so this diagram that is put together by Axe and Schneider-Mackler in 2005 from the orthopedic section. You'll see it crop up in a number of different monographs put out by the orthopedic section as you peruse through these during either in your preparation for the OCS or other stages in your career. And just to orient you to what you're seeing, so on the first column you have the different types of tissues that can be injured within the lower extremity, and across the top you have weeks, days, years, etc. as far as the predictive timelines for the healing of these tissues. The first thing that you notice is that there is a span here, and this is going to be dependent upon patient-specific factors as well as the extent of the trauma that the tissue has undergone. But it provides you some type of guideline to be able to give your patient the recommendation, because it's a very common question that they will ask. They come in with a grade 2 ankle sprain, for instance, and they're saying, how long is this going to take for me to be able to get back? And it's important for you to identify not only the tissue healing timelines for them, but also the functional healing timelines, which we'll discuss further. So this is a chart for your review. You'll see similar charts that otherwise come up in the literature, but the orthopedic section consistently will read. Again, here's a high-level summary, just a different way of looking at it as far as the different types of tissues. So you have the contractile tissues in blue and the non-contractile tissues in red there. So depending on the grade, it would obviously the higher the grade, the longer the duration of time that the tissue needs to be able to adequately heal. With the tendinopathies, this is a little bit, I feel like, more of a challenge from the standpoint that you can have, depending on the amount of viable tissue versus the degenerative component that the tissue has undergone previously, this will determine how long how long it will take for the tissue to heal, as well as the overall prognosis. So one resource that I've put together that has been helpful for my own predictions of these injuries, whether they be operative or non-operative, is the tissue healing timeline in the physical performance Excel spreadsheet. And if you haven't already used this or I haven't shared it with you, it is in the shared drive, and you can see the cascade, folder cascade outlined here. All right, and then you would just click on the performance tissue healing timeline. Okay, you can notice that at the bottom of that Excel spreadsheet that there would be different tabs. Tissue healing timeline is the one that you want. Okay, and then really what it allows you to do is you would put in the respective date of the procedure, and then you would put in the date of whenever you're accessing it. So I populate an example here for you. So say 11/2020, and then so you can either type in the date or you can use the shortcut of hitting Control plus semicolon. And once you do this, it will populate the days, weeks, months, how far out the patient currently is. And then it will also populate the predicted tissue healing timelines as shown in the chart there, depending on, again, contractile tissue, the extent of the injury, and then the variability as far as the minimum and the maximum amount of time that you can predict that tissue to be healed. Okay, additionally is ligamentous injury and the remodeling of the ligament. So there was a great article that was published by Scheffler et al. In 2015 where they looked at the histology and the healing of the ACL graft and how long it actually takes. And so this is an extensive document that I put together that just kind of summarizes what that article had described. A lot of the research you can see, at least in the early post-operative and ongoing, has been really within the animal models versus the human models, from the standpoint that you, just from the ethical issue of actually taking biopsies of the bone graft, or of the healing graft, would be somewhat controversial. But this if you want to kind of go a little bit further in depth, I encourage you to check out the Scheffler article. But I have provided you with the document of the tissue healing for the ligamentization, as it's called. All right, let's talk about the functional timelines now. So the current practice of time-based goals often do not reflect the athlete's functional ability at the time the time-based goals are reached, i.e., just because an athlete is 2 months post-operative or like post-injury of a lateral ankle sprain doesn't necessarily mean that their functional ability is regained at that time, or their prior level of function is what it was, and that they're ready for returning to sport. So when you look at the current literature specifically for ACLR, because we know that there's a multitude and a plethora of research that has been done around this injury, post-ACLR is indicated that a high proportion of athletes do not return to the same level of sport, have increased risk of re-injury, and have increased risk of osteoarthritis at not only the tibial femoral joint, but also at the patellofemoral joint. This may be in part due to the fact that relatively poor outcomes are due to a failure to, one, fully rehab these athletes, and two, to assess them with sufficient rigorous criteria before they pass through the stages of rehabilitation en route to return to sport. So the argument that's being made by Harrington et al. Is the fact that we're not fully rehabbing these athletes, and nor are we putting them under enough rigorous scrutiny in order to determine that they are truly ready for the return to participation. And rather, a lot of sports medicine clinical practice is based upon more of the tissue healing versus the actual functional timeline. Okay, so we've covered the tissue heal, at least defined what is the tissue healing timelines and the functional performance timelines. What we also need to consider is the documented return to sport timelines. Like, what are the current expectations based off different surgical procedures or injuries? Okay, so a recent review by Vasta et al. Looked at the top orthopedic sports medicine procedures. So when we're considering the lower quarter and the surgical procedures that we'll see for each of the given major body regions or major joints, we'll see at the lumbar spine, disc replacements, discectomies, and lumbar fusions. At the hip, FAI. At the knee, meniscus, ACL, PCL. And at the ankle, you'll have your Achilles tendon, your ankle sprains, and your osteochondral lesions. So when we're looking at return to sport timeline summary for the lumbar spine, these are expected when time points at which athletes will return to sport, and this again, it gives you a guideline or expectation, and then also gives your patient the expectation as well. However, knowing that these are not hard and fast, and that it's going to be inherently dependent on how quickly the patient progresses. But it gives you a benchmark as far as how rapidly they may be able to regain their functional capacity prior to returning to play. So dependent upon like the procedure at hand, whether take herniated nucleus pulposus for instance, right? Whether it be a percutaneous discectomy, a microdiscectomy, or a fusion will inherently determine the return to play timeline and how quickly they'll be able to recover from the surgical procedure from a functional standpoint. You also have spondylolisthesis and spondylosis, as well as lumbar stenosis here. You can see that all these procedures people are returning within a year's time, with the fusions taking the longer, and then dependent upon the different procedures that are done, anywhere between 2 to 3 months. Okay, lumbar spine continued. So when we're looking at the actual return to play, so 82% of individuals who undergo surgery for a herniated disc in the lumbar spine will return to sport. And again, it's going to be inherently dependent upon the procedure as well as the initial insult to the tissue that will determine their return to play timeline. Okay, and these slides again are predominantly for your reference, and they summarize not only the expected time point at which people are returning to sport, not only from a tissue healing standpoint, but also from a functional standpoint, and then when the literature has offered the percentile of return to play. So from the hip, we can expect approximately 7.5 months. And then we can also expect that the rate of return to play is about 85%. When we're looking at meniscus injuries, the variables at hand that are going to determine the rate and the time point of return to play is that it's going to be inherently dependent upon the procedure, the athlete's caliber or level of competition, and also the type of meniscus injury, be it like a peripheral or complex tear versus radial tear. So meniscectomy, anywhere between 1.8 to 8.5 months, with a wide range of 60 to 100% of individuals returning to sport. So quite depending on the study that you look at, that there's a large bandwidth here. When you're looking at meniscus repairs, you're at 81 to 90%. And then there's also a lot of variability when you're looking at meniscus repair and ACL. The meniscus transplant, I would say that, at least in my experience, this is kind of a newer procedure, and it's quite challenging for them to return to the same caliber of sport or play that they were at prior to the initial injury. And so, yeah, you're going to get a wide variety here, anywhere between 48 and 80% at prior level of function. All right, looking at ACL reconstruction and PCL reconstruction, that there's going to be quite a spectrum as far as the percentiles that are reported for those that are returning to play, and also considering what does it mean to simply just return to play versus return to their prior level of performance or their prior level of function. And so when you talk about returning to play or returning to participation per se, that you're going to have higher rates, 56 to 83%. But if you're really looking at those individuals that are returning to the competitive level that they once were, that there's significantly less numbers here. So as low as 13% and everything up to 69% have been reported for the ACL, and for your PCLs, these consistently don't do as well. And this is, I think, because there's not as much guidance for us with these, and there's consistently more research that has been coming out as far as like the PCL rehabilitation. We're looking at the foot and the ankle. So the three listed here are your Achilles repair versus your high and your lateral ankle sprains. The Achilles repair, just given the amount of trauma and how vital the plantar surae and the triceps surae complex is to the function of the foot and ankle, and the amount of load storage capacity that is required with sport, that these individuals really are challenged to be able to get back to their prior level of function. It's rated here, at least in the cited study, at 80% will return to play. The time point listed, I think, is quite fast, at 6 months. Consistently, what they've shown is one of the biggest complications with this procedure is the elongation of the tendon. And this really, what they show is between 0 and 6 months post-operatively is that the tissue has the propensity to elongate even post-operatively. And so I would say that this time point of getting them back at 6 months, with the expectation that they've obviously done some loading up until that point, would be in question, despite there being a shift more towards the early mobilization of this patient population. High and lateral ankle sprains will consistently do well as far as their return to play. Over 90% of individuals are expected to return to their prior level of function. OCDs of the ankle. So also, you can see that depending upon the procedures that are performed, this will inherently determine their time point to return to play, and then listed out there for you as they're returning to their prior level of function with large, essentially really large spectrum of the percent of individuals that are returning anywhere between 6 to 100% or 8 to 100% have been reported. All right, and so at least for this pre-lecture content, that concludes this information. Feel free to bring your questions, comments, and feedback, concerns, anything of the like to our discussion section for the live session. Also, feel free to leave comments below within the chat section. Happy to respond to those as well. Next couple slides are just the references, not only for this presentation, but also for the larger live presentation.